to another insightful episode of MedSynapse podcast series. I'm your host, Etvi Shah, and today we are diving into the fascinating world of diagnostic microbiology and infectious disease. With the growing threat of antimicrobial resistance and the evolution of diagnostic technologies, the role of microbiologists is more crucial than ever. And joining me today is someone who is at the forefront of this field, Dr. Madhuri Somani. Dr. Madhuri is an MD, DNB in Clinical Microbiology, a university gold medalist from BJ College in Pune, and an infection control strategist at Quorum Veda. With over a decade of experience in clinical microbiology labs, infectious disease diagnosis, and antimicrobial stewardships, she has played a pivotal role in infection prevention at leading hospitals like Bansal Hospital, Max Super Specialty Hospital, and BJ Medical College. She is also a key figure in accreditation audits and a dedicated DNB guide and a member of esteemed medical societies worldwide. So, Doctor, it is an absolute pleasure to have you with us today and welcome to the podcast.
Thank you, Hitvi. That was very humbling, actually. And I'm currently associated with the Pushpavati Singhania Hospital and Research Institute, PSRI, where I take care of the roles that you just described. Thank you so much for that kind introduction.
Thank you, Doctor, for joining us today. So, Doctor, your expertise spans in clinical microbiology, infectious diseases, and infection prevention as well. So, in the face of rising antimicrobial resistance, how do you see the role of microbiologists evolving in the modern healthcare?
So, that's such a pertinent question, because antimicrobial resistance is actually a silent pandemic. Nobody is really talking about it as much as we need to talk and address it. So India, as you know, has the highest number of annual bacterial infections. We're diagnosing so many infections. Ours is a hub, because we are one of the low and middle income countries. So we are a hub of infectious diseases. And the recent Lancet publication had actually said there were over 4 million deaths worldwide attributable only to antimicrobial resistance. So, the similar data resonates with our country as well. When the ICMR took out the surveillance report, our resistance to basic antibiotics like cephalosporins and fluoroquinolones is as dismal as 0 to 30%. And the next come carbapenems. The resistance to carbapenems is also around 40 to 60% as per that data. So we are actually in a soup right now. And, so antimicrobial resistance, I'm sure our audience does consist of clinicians as well as microbiologists and a lot of students as well. So I'm sure they know what the meaning of antimicrobial resistance is. Basically a bug on which the first and second line antibiotics don't really work. So who gives you the diagnosis? A microbiology laboratory would give you the diagnosis, right? So a microbiologist has a multifaceted role in an antimicrobial resistance pandemic, how to deal with it. So the first and foremost role is what we actually trained for. We need to diagnose and identify the pathogens. So we analyze the clinical samples like blood, respiratory samples like sputum, bronchoalveolar lavage, urine, we culture them in laboratory. We analyze these clinical samples and then we give you a diagnosis of a bacteria, of a virus, of a fungus and a parasite as well. So basically, we help a clinician reach a clinical diagnosis. In addition to that, we also do something called an antimicrobial susceptibility testing, where this particular microorganism is tested against different antimicrobials. And then we report it out as, which particular antibiotic or antimicrobial is susceptible and which is not. So we help guide the clinician, treat the patient accordingly. So this is one primary and foremost role of a clinical microbiologist. And in addition to that, a job of a microbiology laboratory, especially like mine, I'm attached to a hospital. So it's a part of my job to release that cumulative data either 6 monthly or annually. That is called surveillance and generation of an antibiogram. So it's my job to also give the clinicians a data, as to what are our most common microorganisms and what are the common susceptibility patterns. Now, this particular part of my job is called involvement with the antimicrobial stewardship program. Stewardship means judicious use of whatever is available. So if I give you the data, you will know what to use for your patients and what not to use for patients. in addition to that, I also have a role of infection control professional, like you mentioned. Now, a hospital infection control program is aimed at tracking hospital acquired infections. A good quality of care. There is a reason you want to admit your family members to this hospital and not to the other hospital, because the quality of care reflects in how infection control precautions are practiced. So this is one of the major roles that microbiologists have taken up in the past few decades to contain hospital acquired infections, because these hospital acquired infections are inevitably multi-drug resistant, and when, for instance, today I have diagnosed, my lab has given out a report of a multi-drug resistant Klebsiella. My job is also to alert the clinicians, to alert the teams, okay, this particular patient appears to be a reservoir of multi-drug resistant bugs, so please follow your hand hygiene properly, please follow your contact precautions properly, so that this bug doesn't spread amongst the other patients, whereas it is dealing with difficulty in treating this patient. So let us not spread it in the others, and also to protect ourselves from these multi-drug resistant bugs. So we have a role in infection control and epidemiology as well. Then our third role is training and education, So for instance, today's program, we'll be talking today, right? It's a part of my job. We're trying here to spread a message, we're trying to educate people out there. Look, this is a problem and we need to deal with it. So training and communication and, creating awareness also happens to be a part of my job. And we also mentor the students to understand clinical microbiology better, so that once they're clinicians tomorrow, they know how to optimally utilize the microbiology laboratory. So in a nutshell, this is a multifaceted role of a clinical microbiologist today.
Yes, that's a compelling perspective from all sides, and also thank you so much for sharing that. So, would you say that microbiologists today are moving beyond the lab and actively shaping treatment protocols alongside clinicians?
Yeah, that's what I'm talking about, right? See, back then when I actually pursued my training before, even as an undergrad, my perception of clinical microbiology was, maybe just staining, looking into the microscopy and the microscope and fishing, just generating reports from my laboratory. But no, now the role of clinical microbiologist has evolved dramatically, because it is the need of the hour, right? I cannot just sit in my laboratory and, generate my reports. I need to be out there, liaising with the clinicians, be there, present at the patient bedside, and contribute to patient care. I'm a doctor, I'm a medical professional first, a specialist later. So my primary commitment lies towards improving healthcare, improving patient outcomes. So these are my various roles, clinical microbiologists need to step out of the laboratory and discuss, be there with the clinical teams, be always available. All my clinicians in the hospital know that I'm just a phone call away. You need to discuss something, I'm there. You need to expedite a report or a diagnosis faster, I'm there. Because it was my Hippocratic oath, right? I need to be there for my patients. So
yes, I think rightly said. I think holistic approach is really important. So now moving forward, rapid diagnostic tests, especially something like POCT, are revolutionizing infectious disease diagnosis. But they do come with certain limitations. So from your experience, what are the key challenges and how can we improve their accuracy and reliability?
that is actually a very pertinent question, Hetvi, because there is a lot of R&D, there has been a lot of discussion in the past few years, and a lot of research is being driven towards it, because we are dealing with a pandemic, and rapid diagnostic tests do help, to a certain extent. So there's a lot of R&D, there's been a lot of push that's been given towards development of rapid diagnostic tests lately. So like you said, a point of care test. What is a point of care test? A point of care test is something that can be done at the point of care, at perhaps the patient's bedside, nearer to the point of patient's care, rather than in a centralized laboratory. All right. So these tests are usually developed. Their basic purpose of a point of care test is speed, accessibility, and easy to perform. Something you can do quickly in minutes at a patient bedside, come to a diagnosis. For example, if you remember the COVID-19 antigen test, in symptomatic patients, in a few minutes, it just, before the PCR report comes, that gave you a preliminary diagnosis. So That is essentially the purpose of a point of care test, that it can be done in emergency departments, it can be done in the ICUs, it can be done at patient bedsides, it can be done in remote areas where there is still no access for a well equipped or a centralized microbiology laboratory. That is the purpose of a point of care test. These are the advantages, giving a faster diagnosis and decreasing the delay between the diagnosis and treatment. Having said that, these point of care tests or rapid diagnostic tests do have a lot of limitations at this point of time. The limitations primarily that I would like to talk about from a laboratory personnel point of view is the quality assurance. There is still a lack of good regulatory there's still regulatory gaps in manufacturing, in standardization of the test. There are so many companies that are manufacturing these tests, but we still don't have the clear-cut regulations in place to make sure that the sensitivity and specificity, that is the performance parameters of these tests, are up to the mark or not. And once these tests are released into the market, we need to have a good post-market surveillance of these rapid diagnostic tests. We need to see if they actually clinically correlate with the correct patient diagnosis or not. So this is currently still lacking when it comes to quality assurance for manufacturing and post-marketing. And the second part of quality assurance comes to the performance, how we are actually performing these tests in the laboratory. We still don't know if the personnel who are actually doing it at bedside, maybe, or the ICUs, are collecting the sample properly, are performing the test properly or not, are interpreting the test properly or not. Sometimes, for instance, COVID-19 tests were being done at bedside. Sometimes, the nursing was not clear. Ma'am, are we putting the test properly or not? So there's still a lot of gaps in how these tests are performed at bedside also. The third major gap is they have a limited pathogen detection capability. One test, this is COVID-19, this is malaria antigen test, or group B streptococcal urinary antigen test. It targets one bug each. But what you want for your patient ultimately is a comprehensive diagnosis, right? And that comprehensive infectious disease diagnosis can only be given by a centralized laboratory, in which a point of care test is used for screening. This is there or not. And ultimately, the clinical sample is sent to centralized laboratory, which would perform an entire gamut of tests, starting from microscopy, starting to proper culture interpretation, to a full antibiotic susceptibility testing if something grows out. Then you have supplementary comprehensive molecular biology testing as well, and serological and inflammatory markers. So these all support a clinician to get a holistic infectious disease diagnosis. So point of care tests are great, but they are meant to actually supplement the comprehensive infectious disease diagnosis. They have their own role, they have their own important role, but they only complement a centralized laboratory testing. So I'm hoping with time, more and more, funding is given to affordable rapid diagnostic tests as well. Having come to this, I'd like to mention one recent point of care test. We have these syndromic molecular panels that are now being offered. For example, for a respiratory infection, a molecular test in about 45 to 1 minutes to 1 hour can give you can cover 15 bacteria, 7 viruses, 3 fungi, along with respiratory genes. So these huge molecular diagnostic panels are being offered to the clinicians now. But there's one drawback: they're very expensive. So the need of the hour is
affordability.
We need to have affordable, good rapid diagnostic tests. So maybe the government can look into subsidized rates for the end users and put more funding into affordable rapid diagnostic tests. So yes, they are very important. They complement the lab, but yes, they are also the need of the hour right now.
That's true and rightly mentioned. It is actually the need of the hour as well. As we saw during COVID-19, it is actually the need of the hour. So I would like to add here is the skills for sample collections mentioned by you is really important as well. So rightly said. Now, Doctor, antimicrobial resistance like AMR is one of the biggest threats to modern medicine. So what specific microbiological strategies can help clinicians select the most effective therapy while minimizing resistance development?
Thank you, Hetri. That was another important question that I keep, we keep having a lot of talks about it. I've presented a lot of clinical meetings as well. So now what you're talking is called a diagnostic stewardship, being able to use the right test done correctly and done at the right time. So a clinician needs to be knowledgeable about that as well. So that starts like first of all from a clinician should know correct sample. He should know what the clinician should know the correct sample collection, because there is something called a commensal and there's something called a colonizer. All right. So what are commensals? Commensals are, we're not free, we're not sterile. The human body is not sterile. We do carry bacteria, these friendly bacteria, which are called our normal commensals. So what happens is sometimes when the samples are not collected properly, for example, if there's this patient with a respiratory tract infection and the clinician advises the patient, please give your sputum sample. But if the the patient does not know that he's not supposed to contaminate the sputum with his saliva, in which there are normal oral flora, there are normal oral bacteria, the patient would not provide a good sample. And then what would happen is it would come to the laboratory, we'd end up culturing oral commensals and it would lead to a misreporting, right? So it's at the clinician's level, he has to contribute to the pre-analytical factors. He has to educate the patient that this is how you're supposed to collect your sputum sample. A clean cat sputum sample, rinse your mouth properly, cough deeply and give a clean sputum mucoid sample. That is what should be sent in a container. Or if the patient has a urinary tract infection, educate the patient on a clean catch midstream. The perineum has to be cleaned and then some urine has to be allowed to pass and then you have to send a sample to the laboratory. So this particular factor, this particular intervention before the sample comes to the laboratory from the clinician end is extremely important, because you get the wrong sample, the wrong report goes out. It's in a funny way called garbage in, garbage out. Wrong sample coming in as a wrong report going out. So this pre-analytical factor becomes very important, which is an important part of diagnostic stewardship. Then second is being able to recognize what a colonizer is. For instance, we have a patient in the ICU. The patient has an invasive line. You have bypassed all the defense mechanisms. You have intubated the patients. So what happens is there's a biofilm that forms on it. So the drug-resistant bacteria forms a thick biofilm. The patient has no signs and symptoms of infection right now, but if you send a sample, it will grow something or the other. So the clinician should look at the report and should analyze it with respect to the patient's clinical features. Does the patient have fever? Does the patient have new chest infiltrates? Are the patient's pus cells in the blood, the WBCs in the blood elevated? Are the patient's additional inflammatory markers elevated? So clinician has to look and interpret the report holistically, not just go and treat every report that comes into your hand. All right, so this particular factor of interpretation becomes very important. Then after this, clinician has a very important role to play in stewardship, antimicrobial stewardship. Stewardship in a sense, you have the susceptibility report available with you. All right, so you need to interpret the values on it and you have to know which correct. First of all, to de-escalate as in if the patient is getting a high antibiotic, please bring it down to a lower antibiotic. Why? Because if the patient continues getting a higher antibiotic, even when he has a sensitive bug, the patient's normal flora, gut flora, transitions from sensitive to resistance. That is called a selection pressure. So it is your moral responsibility to just give what is needed, not overdo.
Yeah, that's quite often seen also.
Yes. So that is very important that the clinician should know, because what you are doing is that is why we have an AMR pandemic right now, right? Because maybe over the time we have mistreated or overtreated and these bacteria have multiplied and currently changed the entire epidemiology of the resistance pattern. So these are a few factors that clinician needs to remember. Then also as part of stewardship is knowledge of the pharmacology of the drugs, the pharmacokinetics and the pharmacodynamics. For instance, one particular antibiotic, tigecycline, cannot be used for treatment of bloodstream infections. So when the report is with you and tigecycline is sensitive, you have to know that no, I am not supposed to use tigecycline for treatment. I don't, at my end, actually don't report it only from my laboratory so that you don't use it only. But things like these. Clinicians have to be well versed with what antibiotic to be used for what infection. Then finally, another important role of a clinician here is liaison with the microbiology laboratory for antimicrobial resistance surveillance. They also have to liaise with us. They have to follow they have to liaise with the infection control team of the hospital, because unless you are following your hospital infection control precautions properly, you are the topmost rung. The nursing staff and the other rungs of staff looks up to you. So if you're following good infection control precautions, that would mitigate spread of antimicrobial resistance, and the other staff would also emulate you. And so this is how a clinician can leverage a microbiology laboratory sort of better.
Yes, I think that's an interesting take. On that similar note only, what are some of the most common mistakes clinicians make and how can they be avoided?
Yes. I have actually, over the many years of that I've worked and liaised with clinicians, yes, I have had cases where the reports have been misinterpreted. So, like I mentioned before, this misinterpretation, first of all, starts with mistaking a colonizer to be a pathogen. I've had so many discussions with clinicians where I've had a hard time explaining them. Sir, ये pathogenic नहीं है, please इसको मत treat कीजिए. It's a colonizer. So that particular concept of colonization is so hard to dig into the clinicians, because they're scared. My patient is isolated this bug, मुझे तो treat करना ही पड़ेगा. नहीं treat करना पड़ेगा. Please analyze the report with respect to the complete clinical presentation. Look at the patient's clinical features. Are there signs and symptoms suggestive of an infection? Are the WBC counts elevated? Are your CRPs and procalcitonin, these inflammatory markers elevated or not? Look at an entire whole picture and then go ahead and decide whether you actually need to treat. Also, in my microbiology reporting, I give colony forming units. It's some samples like bile and urine. So these knowledge of these colony forming units, the quantitation of the organism also needs to be taken into the picture. So the clinician needs to understand that the amount of bacteria that I've isolated is less. I don't really need to treat it. What came out in the microscopy? Were there pus cells in the microscopy? Were there enough number of pus cells? So, you need to analyze it completely. And then second, like I mentioned before, commensals, you have to be adequately knowledgeable about presence of commensals. A very common situation that I still encounter sometimes is I get only one blood culture which grows something called coagulase negative staphylococcus. This coagulase negative staphylococcus is a normal commensal on skin. So if the blood culture is not collected properly with proper aseptic precautions, obviously one blood culture will grow, and then the clinician is confused. Do I need to treat this or do I not need to treat this? What is the way out? Send me 2 or 3 pairs of blood cultures collected with adequate aseptic precautions, because that is what is important to diagnose. There is an entity called infective endocarditis, the infection of the endocardium of the heart. So these blood cultures, and coagulase negative staphylococcus can be pathogenic in such a case. So it's your job to send me adequate number of cultures collected with adequate asepsis. So, this is sometimes, these are some reports that clinicians commonly misinterpret. एक blood culture में कौन से मुझे antibiotic like higher antibiotic vancomycin तो देना ही पड़ेगा. So that again leads to collateral damage. Then third is, like I mentioned, the antibiotic susceptibility reporting. You need to know which antibiotic to use, how to use, whether to use or not, to de-escalate. All right. And I feel, what else does a clinician misinterpret? Basically, these are the main 3, areas where I felt that the tests are misinterpreted. Second thing, I would also want to mention that clinicians should also use supplementary inflammatory markers like a CRP, C-reactive protein, or procalcitonin to maybe initiate or discontinue antibiotic treatment. And they should also, when you get there, like I mentioned, the molecular diagnostic panels, if there is a virus in your report, there is no bacteria in your report, please don't give antibacterials. Give a targeted therapy once you have a report in your hand, instead of continuing a broad spectrum antibiotic therapy. My patient is responding, मुझे तो continue करना ही पड़ेगा. So correctly interpreting the report and stopping the therapy where it needs to be stopped.
Yeah.
So these, I feel, are my personal challenges that I have faced. And having said that, it's my job as a microbiologist also to continuously collaborate with the clinicians, continuously educate them, We meet in clinical meetings, we need to discuss cases, and I need to put forth my point of view. So it's my job also to educate them, what are pathogens, what are commensals. Because they have their own set of expertise, a cardiologist has his own set of expertise. So continuously educating their clinicians, creating awareness on how to interpret microbiology reports is also a part of my job. So
Yeah, I think that's a great point, and collaboration is also must. Like microbiologists collaborating with physicians is must, and spreading misinformation these days is quite easy and unreliable as well, right? So, doctor, before we wrap up, you are a key opinion leader in this space. So, what message would you like to share with healthcare professionals on leveraging microbiology for better patient care?
yeah. So yes, as a clinical microbiologist, I would like to give out a message to the clinicians first that please utilize your microbiology laboratory. At least in tier 2 cities, you have options of good microbiology laboratories. But even in tier 2, tier 3, where just utilize whatever is available to you. Go ahead, send cultures, send diagnostic tests. Don't just treat on the basis of a probabilistic diagnosis. Because now microbiology is actually evolved in the past 10-15 years. We have newer, better diagnostic modalities available. Please go ahead and utilize the diagnostic laboratory to come to a comprehensive clinical diagnosis. And for the general public, I would like to say that, first and most importantly, don't overuse or misuse the antibiotics. We have this tendency, khasi ho gayi, or maybe I'm having diarrhea or food poisoning. You walk to a pharmacy store. I have these symptoms. Aap mujhe ofloxonidazole de dijiye, ya mujhe de dijiye, and then you take it just for 2 days maybe and just stop it. Ab to main theek ho gaya. No, that is a wrong practice. First of all, go and get yourself tested. Seek a doctor. First, get yourself clinically diagnosed first. No, once you have a diagnosis, it's a viral. You won't need an azithromycin or a moxiclav for it. So the first thing is go out, reach out to your doctor, get yourself diagnosed, and then when you're given an antibiotic prescription, make sure you take the correct dose as prescribed to you. Take it for the full 5 to 7 days that you have been prescribed for, and also use palliative care. Like drink a lot of water if you have UTI, so that you pass out more of the bacteria, and maybe if you have upper respiratory warm water or betadine perhaps, so that you get an early recovery. So don't misuse and overuse antibiotics. And also, I think we need to talk more about antimicrobial resistance in general, as the way we talk about women empowerment. I feel it's so important that we need to go out and we need to talk, we need to discuss more about antimicrobial resistance pandemic, because I'm personally so scared. I'm leaving a world full of resistant bugs for my son tomorrow, God forbid, one of my family members is admitted to a hospital and contracts a hospital-acquired infection, which is, like I said, most often multi-drug resistance. We have no options left to treat. It's a very deep-seated, deep-rooted problem, and I think it can be addressed if we sort of talk more about it, like we are talking today. So yeah, this is, I think, the message I would want to give as a microbiologist. Please utilize, get yourself diagnosed, and when you get a treatment, please take your treatment properly.
Yeah, that's a powerful message indeed. And I think it's clear the microbiology isn't just about detecting pathogens, it's about driving precise patient-centric care also. So, Doctor, this has been an incredibly enlightening discussion, and your insights into diagnostic microbiology and infection control are invaluable.
Thank you so much, Hedri. For me, I'm so committed. I feel I need to put my role, play my role well as a part of dealing with antimicrobial resistance. So, you inviting me to this lovely discussion and allowing me to put forth my point of view, I'm thankful to you as well. So, thank you so much for having me over.
And I'm sure our audience has gained a lot from this conversation. So thank you so much for joining us today. And to our listeners, thank you for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and stay informed. Bye.